All right, good afternoon, everyone. We are today going to talk about just the basics of cardiac CT. It's a timely lecture. I know the new academic year has started, and those who are rotating through the CT lab know how busy we are. And oftentimes, you have a lot of questions that sometimes we kind of speed through and don't get the real chance to explain to you why we're doing what we're doing. So I hope at least in this talk, we kind of hit on a lot of key questions that you may have had brewing in your mind, but were afraid to ask. And then Dr. Chang will follow this up by another talk, which is the advanced CT techniques. And you'll see ours will kind of overlap a little bit because I'm going to hint at things that he's going to be talking about. So you'll get a very good flavor, I hope, by the end of this talk. So we know, cardiac CT is an advanced cardiac imaging technique along with PET and MRI. And these techniques can really do a very comprehensive assessment of the heart and its function. And just listed is some of the different things that we readily evaluate in our lab. And, and as these conferences go on throughout the year, we hope to bring you interesting cases demonstrating how we use CT in our everyday practice. But really, to be honest with you, today's talk is really how do we get the pretty images that we do to answer the clinical question you guys are always concerned about. So we'll talk a little bit about the basics of a CT scanner. We'll keep it simple. We'll talk a little bit about different types of resolution that are important for CT and of course are important for any kind of imaging technique. Spatial, temporal, contrast. And then we'll talk a lot about how we actually go about acquiring these images and how you can have a very successful conversation with your technologist as to how to acquire images to answer the clinical question at hand. So before we kind of get into CT, we have to we have to step back a little bit. It all started probably with chest x-rays, right? And here is a classic AP chest x-ray. And the benefits of, and what it's representing is it's really an attenuation map, right? You're able to see, different structures within the chest attenuate x-rays differently, and it creates an image. And as we know, it's very beneficial to our evaluation of a patient, but there's a problem. It's hard to localize things. So you may find an abnormality in a certain location, but you're not able to pinpoint exactly where that abnormality is. So how do you go around that, right? That's where the two-view, or the PA and lateral X-ray is very helpful. It gives you another perspective at 90 degrees, which can it helps you a lot to be able to localize things. So if you had, abnormality here on the AP, it's in the heart, but on the PA and lateral, it's very helpful to help you identify, what chamber of the heart possibly the abnormality is. So, having multiple projections is helpful. So, some of y'all may have seen this. This is the future King of England. And, point of views matter. I mean, he's really not doing anything bad here. If you have the right projection, you're able to tell a lot of information. So it's all about points of view, right? And why I bring all of this up is because what if you had an unlimited number of projections? And that's really what CT is. You have unlimited projections around the patient's heart, and what that allows you to be able to do is have a very good idea of spatial relationships, spatial anatomy, to be able to localize things. And that's what CT is. It's multiple projections of an object you're trying to image. And in one example that I read, a single CT image can be almost 800 rays of X-rays taken at almost 1,000 different projection angles. So, just to give you how powerful, you can imagine how much information you can get from so many different projections. And that's really what we're going to be talking about. Once we see, yes, sir.
So in a regular X-ray, you send the X-ray, pass it to the tissue, and you have it in a receptor here.
On a detector, yes.
In the CT then, each of those yellow things are sending and receiving?
No, one is sending, one is receiving. I'll show you the guts of a CT scanner on one of the upcoming slides.
Okay.
I'll show you that. So, you know, and this is, once you get all of these different projections from different angles, you're able to create a short axis slice of the patient's anatomy. You know, you can imagine what you are actually looking at on the CT screen is a 2D image, but it's actually, you know, a cross-section of some 3D anatomy. So think of it, you have a loaf of bread and you've taken a slice out of it. That's kind of what, you know, CT images start looking like. So this is what Dr. Quinones' question was about. This is, what are the guts of a CT scanner? And really, it's 4 different things. It's a gantry, you know, which is the table and the entry into the bore. You've got the X-ray tube, you've got a detector, and you've got the main control console, which is, you know, a computer station where a lot of post-processing is done, where a lot of input function is done to be able to get you these pretty images. And so here's what, if you were to take off, that Philips 64 was our old scanner before our dual source. If you take off that front cover, this is what you're going to see inside of it. And what you'll note is you'll see an X-ray tube, and directly across from, you'll have a collimator. And a lot of these things are going to be very similar to what you're going to hear Dr. Mamarian talk when he talks about SPECT. But instead of transmission, he will talk about emission. So, but the idea is you'll have an X-ray source, which is our X-ray tube. You'll have collimators. The collimators are a substance that shape the beam. And then you'll have the object being imaged in the middle of the bore, followed by a series of detectors which actually detect the X-rays as they are going through the patient and are able to see how much the X-ray beam is being attenuated. And so we'll get into that. But you know, nowadays, you know, I wanted to kind of mix old with new. So you've seen a progression from the 64 slice days to now what we have is these dual source scanners. They have very similar components, but you have a second head mounted at 90 degrees. So the beauty of you know, this, and that this is kind of the arrangement that you would see if you were took the bore off of those scanners. So what are, you know, X-ray goes to the patient, it's detected by a detector, it's emitted from an X-ray tube. What are you actually measuring? Well, you're actually measuring an attenuation coefficient. And this attenuation coefficient, just, you know, different structures in the body will attenuate X-rays differently. And what eventually gets to the detector is what we call an attenuation, some value, a linear attenuation value. And with this occasion then, you can then assign it to what you're more comfortable calling it as a Hounsfield unit. So this takes this attenuation number that's obtained by the CT, it converts it through this formula into a CT density value or a Hounsfield unit, which you guys are very used and familiar with. And as you know, different substances have different Hounsfield units. Now, of course, we don't have our contrast resolution is not as great as other techniques such as SPECT or CMR, but they are objects that we can clearly identify with great specificity as to what they are based on their Hounsfield units. So air generally tends to have Hounsfield units in the -1000s. Fats will be up from anywhere, also in the minuses, but usually around the up to 100. Water, which is what this CT density, these Hounsfield units were calibrated to, is considered 0. Bone will be around 300 to 500, and metal will be a much more positive number than that, usually up in the 1000s. So when we talk about Hounsfield units, we're just talking about how much that X-ray beam is attenuated when it hits that object. So the computer, so how do you actually go and then create these images? So you can imagine that you have this patient, he's in the scanner, you've created numerous projections around them with numerous X-ray beams. And what you can imagine is for each pixel, you've collected a CT Hounsfield unit or linear attenuation coefficient for each of those pixels, depending on how much attenuation that pixel saw. And with CT, most of it is grayscale. So you can imagine then if you put all these grayscales together, you can start forming an image of the original structure. It's a little bit, of course, more complicated than that. Once you've acquired the scan data, we have to recreate this image. You'll hear about filtered back projection again when we talk about nuclear. Nuclear, again, and CT are very, very similar processes. And this is just a reconstruction algorithm that you've acquired this data in order to recreate the original image. They use a method called filtered back projection, which is exactly what we use in nuclear to create a digital image. Last week we had heard about Fourier transformation for MRI. So with CT, it's a little bit different mathematics. So, and then just, we've discussed a little bit about the basics in the gut of a scanner. And this is just a quick slide. We won't spend too much time on it. But showing you that this is very recent history. A lot of y'all, of course, are younger, but definitely your parents, definitely my generation. This was, very recent. The explosion with CT is recent, especially with cardiac CT is very, very recent. All right, so now let's get into really the heart of this talk is, the object we're imaging is a moving structure, probably the only moving structure in the human body, right? The human heart beats how many times per second? So you have to create a still image of a moving structure. So there's a lot of technical demands here. We know these coronary arteries, when you're in the cath lab, they're 2 to 3 millimeters. So you have very small anatomy. It can be very tortuous vessels. We know it's a structure that's rapidly moving. So, in order to create these pristine images that you see, how are we going to do that? What are the qualities that are needed from the scanner in order to freeze the heart? So first thing you have to have is a technique that has very high spatial resolution. You want to see small anatomy. We'll talk about that. You have to have a technique that has a very high shutter speed. You want to be able to freeze the object, just like a cheetah running, in the desert. In the safaris, you have a camera with a very fast shutter speed, and then you have a very still image. Same concept here. We have to have a CT machine that has a high temporal resolution in order to freeze the heart. You want to be able to do this quickly. We don't have time like the MRI people do. We got to do it fast. And not only does it have to be done fast, if we can get it done in one single breath hold and a large coverage, that would be the prize. We want a technique that can be synchronized to the cardiac cycle because obviously, as we're going to get into here, we're cardiologists. For us, it matters whether you're in systole and diastole, and for the reasons that I'm going to get into, it's very important we know when the image was acquired. And finally, a little bit about contrast resolution, not the strength of CT, but how we can make it a strength for us. So let's talk a little bit about gating. So as we talked about, we want to be able to gate our images to the cardiac cycle. And there's reasons for that. The right coronary artery is the artery that is the most mobile. Just like when y'all are in the cath lab, that right artery is always flopping around. The left are a lot more stable. And what we know from a lot of elegant studies, and this is just a graph of that, there's actually 2 time points where the coronary arteries, especially the right coronary artery, are still. And that's in where we like to image in end diastole. You can imagine the heart is now filling up with blood. The arteries should be a little bit still. And then a second time point, which in the past we couldn't take advantage of, but now with scanners with very fast temporal resolution we can take advantage of, believe it or not, in end systole, there's another time point where these coronary arteries are still. And so this is why it's important for us to be able to gate our images. If we are going to take a picture of a moving object, we want to take it when it's the most still. So we are going to be trying to take images in a very brief period of time, somewhere in mid to end diastole, and if we can, somewhere in end systole. So hence why we have to be able to know where in the cardiac cycle the images are. And this is just an example of a study that, y'all have seen this, nothing new here. A study without ECG gating, the RC is a complete motion blur. Whereas if you do have ECG gating, you can go to the phase where you expect the coronary artery to be very still and diastole here, and you can see a beautifully formed artery. So, and this just takes us onto this discussion is, about temporal resolution. So temporal resolution can be defined as, and it's really vital for coronary imaging, can be defined as your ability to resolve fast-moving objects, time required to acquire, or another definition is the time required to one image. And what we want to do with cardiac CT is, we know, and as I'll show you in the next slides, these time periods where you can take a picture are short. So you want to have a technique that has a temporal resolution that's fast, because normally you have a short period of time to image. Now there's ways we get around that. We'll talk about that. But before we do, what are some of the primary components that help that predict temporal resolution? First is your gantry rotation time. So back in the Wenry days when we had a 60-floor size scanner, and even now, there's only a set amount, in order to create an image, you have to go around the patient 180 degrees. So how fast can you get to that 180 degrees? Previously there was, up till now with this, they have been limited as to how fast they can actually spin this machine. There's tremendous, obviously when we took the cover off that scanner, there's a lot of equipment there. It's very, very heavy. There's tremendous amounts of G-forces that are generated when you spin a camera 180 degrees. So we were limited by how fast, your temporal resolution was limited by how fast you could spin that gantry. Other newer techniques now to improve temporal resolution, we'll get a lot into this, is our dual source CT scanners. Now you have two heads. So they're taking you have two heads positioned at 90 degrees to each other. So you literally now only, instead of going 180 degrees, you only have to spin 90 degrees. Because now the second head will cover the opposing 90 degrees of information. So that's helped improve our temporal resolution. I'll show you some numbers on that. There's another way we do it. This is what CMR does, multi-segment reconstruction. We'll save that. Daksha will fill us in more about that on another time. So how can we improve our, like I said, so we're kind of often limited, especially with our 60-floor size scanners, as to how much temporal resolution we have. It's with that scanner, I believe, with the old Philips, it was about 180 milliseconds. So what can we do to still be able to take acceptable images? Well, one of the first things is, why not prolong diastole? Systole is generally around 200, 250 milliseconds. That's kind of a fixed period, whether your heart rate's very slow or your heart rate's very fast. But your diastole is very much dependent on your heart rate. So as your heart rate speeds up, your diastolic period is very small. This is everything you guys know from ventricular filling patterns from echo or any other technique. Whereas when your heart rate is very slow, systole is preserved, diastole is prolonged. So one of the things we used to do with the old 64-slice scanners is load these patients up on beta blockers. Make sure they have plenty of beta blockers on board, because we want a nice slow heart rate. We want a nice prolonged period in diastole, mid to end diastole, where we could take sufficiently still images with the temporal resolution of our scanner. So the importance of heart rate control, heart rate control, heart rate control. And in those days, we used to be very aggressive. We used to go for heart rates less than 65 and ideally less than 60. And there were days where I remember they'd get 400 of PO metoprolol plus a bunch of IV, and if that was enough, we'd bring them, beta block them overnight and bring them the following morning. So, this was something we took very, very seriously. And this is just a graph showing you that, people have studied this very systematically, showing you that, if you control the heart rate, and this is just a graph showing you at different heart rates, image quality is much better in certain time points. Image quality is much better when your heart rate is slow. It's much better in end diastole, and it's much better in end systole if you can get, if you have the sufficient temporal resolution to nail that portion of the cardiac cycle when the heart is also still. So I thought, I should show you what it looks like to see a gantry spinning around, and I don't think any of us would put our heads in there if if we knew what was going on behind that cover. But you can see that there are a tremendous amount of force being generated here. They say up to 28 Gs. And back in the day, our 64-slice scanner, it took 330 milliseconds to go 360 degrees. To create an image, you only need 180 degrees, so that was about 180 milliseconds of temporal resolution. And of course, the physics behind this, to be able to spin like this, are a field of itself. Then came, someone thought, hey, nuclear cameras have two heads. Why can't we do the same with CT? And that is the technology we have today. Upstairs and across the street, we have two dual source CT scanners. And the concept is very simple. You have another head, another X-ray source and detector located exactly orthogonal to the original first one. And the concept is, well, now I only have to spin, instead of 180 degrees, I only have to spin 90 degrees, because you'll get the other 90 degrees that you need to create the image from the second detector. So you've actually tremendously improved your temporal resolution. And we'll talk that, let's say if you were to put it on the old scanner, which rotated in 333 milliseconds, the 64 slice, then your temporal resolution with that scanner would be down to 83 milliseconds. And you can imagine why that's important. Well, now we can image at a lot faster heart rates, because we have the temporal resolution to be able to still capture images, still images of the heart. We could give less beta blockers. So tremendous benefits there, and we'll talk about less radiation. The scanner that we have, believe it or not, has a temporal resolution of 66 milliseconds, and we'll talk about that. So, okay, this was me making slides better yesterday. Okay, so we've talked about temporal resolution. Now, of course, the other important thing is temporal resolution. This is where CT is king. No one beats us. Okay? We have the best temporal resolution of any imaging technique there is, other than a spatial resolution, other than a patient who goes to the cath lab. And wait, I have a slide for that one too. So our spatial resolution in the in-plane direction is down to 0.5 millimeters. Now, what's important for y'all to know is this is completely defined by the geometric characteristics of the scanner with the different vendors as to how they come up with, there's nothing that we can control. The things that we control are very similar to what's important with any imaging technique. At the end, what you're displaying is a pixel size. You want to make sure that you have a small field of view and therefore small pixel sizes. But the actual spatial resolution that the scanner is able to acquire is all determined by the characteristics of that scanner. That's in the XY axis, the in-plane axis. The through plane, which is your Z-axis resolution, just slightly worse. It's anywhere from 0.5 to 0.625. And this is really dependent on the thickness of the thickness of the detectors in the Z-axis. And we'll talk a little bit about that. But what's important to note is that, what I want you to to know is that we have the highest spatial resolution. It's dictated by the particular scanner that you have. And this is the only technique that gives you spatial resolution that is isotropic, or equal in the X, Y, and Z planes. And that's very, very important, because when we move through these data sets with NPR, we don't have any loss of information. We don't have any partial voluming. And so a very, very important feature unique to CT. Talking about Z-axis resolution, all the different vendors have a different setup of how thick their collimators are. And this is just an example of some different setups that different vendors have. They not only dictate your Z-axis resolution, but it also tells you how much coverage of the heart is there. So these are all just, when we go to buy a scanner, we have to compare all of these different things to see what we want to achieve. There is a restriction to how thin you can make these collimators in the Z-axis. Noise and radiation go up tremendously. But, this field is very young and very, very rapidly growing. And I'll show you a slide here in a second. And this is just a slide I won't spend too much time on, that when you do, in the end, when you do have to project your images on a screen, pixel size becomes very important. That is dictated by your field of view. Your matrix size is generally fixed at 512 to 512, and so we really want to make sure that you cone down to the heart and that you're using around a 250 millimeter field of view. Okay, so what are the problems with not having sufficient spatial resolution? So the cath lab is 0.2 millimeters. We're around 0.5. So this is where our specificity suffers, right? Because the idea is that, and this is a nice little graph there on the bottom left-hand side of the screen, that if you had perfect resolution, you would be able to make out a perfect circle. If you don't have perfect resolution, then some of this black box will be covered by pixels. Will have there'll be pixels with mixed intensities, and therefore they'll be assigned different CT values. So that's where you get this partial voluming idea, where you get one pixel with two different things in it, and you don't get, you get a little mixture of in the image. Poor spatial resolution is also responsible for the blooming artifacts that we see with CT. Both of these end result of this, both the partial voluming, both with calcium blooming, is where we suffer on specificity, where we may suggest that there's a significant stenosis, but you take them to the cath lab, you see a stenosis, but it's not as bad as we say. It's because we tend to overestimate because of our spatial resolution being inferior to the cath lab. Well, and we do our best to get around this, hence why we give nitrates. We're dealing with very small arteries. If you plump them up, make them bigger, then now you're hopefully, you have the spatial resolution sufficient to be able to image that very small vessel. So hence why we give nitrates. And then this is just a slide showing you why isotropic voxels are so important. It's really for multi-planar reconstruction. It's our ability to move freely through any plane we desire without any loss of spatial resolution, without any effect of partial voluming. So very, very important aspect for CT. And this is just a slide showing you the different spatial resolutions and temporal resolutions. You can see here that most of the CT technology is kind of stuck at 0.5 to 0.6 spatial resolution. Best is cath lab at 0.2. And then when it comes to temporal resolution, we're now down to 66 milliseconds with the dual source. But invasive angiography, still has a very high temporal resolution. Then comes this game changer. This was introduced at the RSNA in 2017. Dr. Chang will probably tell us more when we come to the advanced side of CT. But this is now, believe it or not, this is being readily tested in research as of now, and can now resolve down to 0.15 millimeters, or 150 microns. So now you have a technique that has spatial resolution equivalent to the cath lab. So maybe completely, maybe invasive angiography, maybe in the future, a way of the past. No to Omar Jarudi, very important lesson. Okay. So I think we'll hear a lot about this, but this technique is out there and is a tremendous game changer, at least for imaging. All right, so next is the issue of coverage. So remember, we want to be a fast technique. So not only do we want to do how do we do fast imaging? Well, we got to take a picture of the heart quickly. That means we got to cover as much of the heart as we can. And there's a lot of benefits from doing things fast. If you do things fast, well, it's less problems for the patient. They get less radiation because you're done quicker. Contrast dose is less because you don't need to. Your machine isn't on for too much time. So what I'm going to show you is how all the different vendors have come out with different detector configurations and as to how much coverage they want to give you. So, back in the day, we had the Philips Brilliance IST. You could see we had about 75 millimeters of coverage. The Flash, you can see, has less. It's dual-headed, but it's less at 38 millimeters. But there is one machine out there, the Toshiba, which actually has 16 centimeters of coverage. So this is a scanner that can cover the heart in one heartbeat, right? Because you're seeing the entire heart. All these other techniques, all these other scanners, because they have a smaller distance that they can image, they may have to revolve around the patient 1 or 2 extra heartbeats to get all the data they need. So this is, again, just a slide showing you that different vendors have different setup configurations. And it becomes important for something like this. If you have a 4-slice scanner, well, it's going to take several pictures for you to get the heart. You can see as the progression from 16 slice to 64 slice, now to the 320 slice. With the 320 slice, you can, because it has such a large coverage, you can cover that entire heart in one cardiac cycle. So people often talk about slices. They're talking about how much coverage they can get of the heart. And this is just a summary slide showing you, a discussion about, what is the different detector and, rotation times and temporal resolutions of all these different machines that are out there. And, temporal resolution on most of them is the same until you get to, of course, the dual source. Spatial resolution is about the same, but they have different coverages. Okay, so we talked about temporal, we talked about spatial resolution, we talked about coverage. The other important thing about CT, we talked about EKG gating, all very important things that you need to be able to image moving structures. The other very important thing is, of course, contrast resolution. Contrast resolution, as you know, if you've ever seen a CAT scan without any contrast, is not the strength of CT. We have very poor contrast resolution as a technique in general. However, we improve upon this by giving iodinated contrast. And the reason is through the intravascular system. And then once, and the rest of the optimization of the images in order to improve our contrast resolution is really how we time the bolus and how much contrast iodine you should give and at what speed and volume. Those are, what we play. But the main thing is, you want to improve contrast resolution. For us, you got to give contrast, period. There are newer techniques coming out. Dr. Chang will probably hit on this as well in his more advanced talk, is these dual energy, where you can determine tissue characteristics based on how a tissue behaves under different photon energies. But a discussion for another day. I brought this slide because this kind of shows a very important slide because it's kind of counterintuitive. This is a slide that shows you our typical range where X-rays are delivered. And you can see here that, and this is your attenuation here. Remember the linear attenuation coefficient? And you can see that for iodine, which is circled here in this red box, you know, in the typical range of X-rays that you deliver, you're going to get the brightest image when you administer iodine. So remember, contrast resolution improves with iodine. But what I wanted to show you was, notice what happens. We generally image around 120 kVp. Notice what happens as you go down kVp. Your linear attenuation coefficient, the amount of attenuation that you have, actually improves with the less energy photon that you're delivering. You're more in this, what they call this K zone of iodine. And this is just a representative picture of that, is that, you know, you have a picture here. Yes, this 120 kVp looks sharper. That's because you have less noise in the image. But when you drop your kVp, the brightness of the image, the amount of attenuation that is actually happening is greater than when you're imaging at higher kVps. So you'll see there's a lot of emphasis sometimes in our lab where we try our best to figure out the size of the patient, whether we can get away with low kVp. Because low kVp not only means less radiation to the patient, less higher energy photons going through that patient, but it also means that we actually get a better interaction with the iodine, and we may get a brighter picture of those vascular structures. And then this is just a different summary slide going over the different types of, you know, resolutions of different imaging techniques. And, you know, spatial resolution, Dr. Shah, remember this, CT is king. For contrast resolution, MRI is very high, but believe it or not, SPECT and PET are higher. And then temporal resolution, you know, nothing beats echo. So some just simple take-home points y'all already know. All right, so now I kind of divided my talk, you know, how do we scan? You know, these are the things that y'all are always asking us. So I had to do it. I think you should know a little bit of history because these are the scanners that are most places, not these, you know, fancy toys we may have here. So we're going to talk a little bit how to scan on the 64 slice. If this makes sense to you, scanning on the dual source will make more sense to you. So there are about 3 different ways we used to scan back in the day. One was retrospective scanning. We'll talk about that. Basically, the radiation is on throughout the image. The second way we used to do it was retrospective, but we used to modulate the dose. We used to only deliver the most radiation when we needed it most in the most still portions of the cardiac cycle, and then tone down the radiation beam when we didn't need it as a way to save radiation. And then finally someone said, you know what, why even bother with toning down the radiation? Let's just turn it off completely, and that became prospective scanning. So you only delivered radiation only at this phase of the cardiac cycle where you wanted to image. And this next few slides will be just a little bit more detailed about that. In this retrospective scanning, you know, you're delivering radiation throughout the cardiac cycle. The patient is moving in a helical fashion continuously through the bore of the table, and, you know, your detectors are going around the patient's chest, delivering radiation throughout the cardiac cycle. Benefits of this? Well, number one, you could retrospectively go back and go to any particular phase of the cardiac cycle you wanted to evaluate. So if you had motion in one phase, let's say the 40% phase, you could go and you know, look at the 70% phase and see if that portion of the artery was still over there. You had information throughout the cardiac cycle, so you could look at functional information. This all, and you are less at risk for arrhythmias. You know, arrhythmias, one arrhythmia here and there can really destroy an image for us. So this was more forgiving because you had more phases to look through in order to identify the information that you needed. But of course, this comes at a cost. If the radiation is always on throughout the cardiac cycle, these were techniques that delivered the highest radiation doses. So, and this is just an example of retrospective gating. I could go back and create an image at any portion of the cardiac cycle I wanted. If I wasn't sufficient with how this RCA looked at the 60, I could recreate it at the 70 and 80 to make sure if I did see an abnormality, it wasn't due to motion or a PVC or whatnot. When it comes to retrospective gating, it's important to have this concept of pitch. The idea here is, if you just look at this top left here, is that, if the patient is if the gantry is continuously on and you have a patient going through the scanner, you don't want to miss any portion of the heart. So you want a pitch that is 1, where your table speed perfectly matches the width of the collimator. So you get, the heart is completely covered without loss of data. Or even better yet, if you could overlap and have a pitch that's less than 1, where you collect overlapping data. Because if you do have any problems, then you still have enough information from someplace else where you can get to recreate the original image. Last thing, what you don't want is to have a pitch greater than 1. You don't want your table speed so fast that you don't collect, you don't completely image the heart or miss portions of the heart, because then that's blank data you don't have. So with retrospective gating, it was very important to have a very low pitch in order to image the entire heart. And then this is just an example with retrospective gating. I have information throughout the cardiac cycle. I can create beautiful functional images like this. Here we're quantitating a left ventricular ejection fraction and volume. And it becomes very important for when patients are sent for cases of valves, or if for mass cases, because that's when functional information is needed, right? So that's when retrospective gating is employed now, when we need functional imaging. Then came the idea, as we were saying, that, why don't we just tone down the radiation during the phases that we're not interested in? We'll still get functional information, but we won't, completely fry these patients. So this was retrospective gating with dose modulation. Here again, maximal MAs were delivered in mid to end diastole when the heart is most still. The rest of the cardiac phases, very low amount of MAs were given. What does that create? It creates an image where your end systolic imaging is blurry, fuzzy, maybe not able to read the coronaries, but could be sufficient for getting some volumetric information, whereas your end diastolic information has the least noise and the best SNR. So, and we used to do this a lot back in the day, EKG with dose modulation. And radiation doses were 30% better. Then, people said, why not just only radiate the portion of the cardiac cycle you're interested in? And that is the concept of prospective gating, where, you figure out, based on your EKG strip you're seeing, you look at the R wave and you say, okay, for X amount of time from the onset of the R wave, I'm going to image. That's where the heart will likely be most still, and I'm going to take a picture only then. And the way this is done is, let's see if it's in the next picture. Yeah, so this is kind of an example of that. Slab 1 is taken over 1 heartbeat. The table moves, Then slab 2 is taken over the next cardiac cycle. The table moves. Slab 3 is taken. The table moves. Slab 4 is taken. So you get an actual stitching of information. So you create an image from, if it's an image of 4 pieces, those 4 pieces are put together. So this was prospective gating. Now, benefits were the least amount of radiation of all the techniques. You only had radiation be delivered during a certain portion of the cardiac cycle. Problems? 1 arrhythmia and it's a bad day. You're redoing the study. Scanners such as the 320 slice, remember, has full coverage. They actually, the main way they like to image is with prospective scanning, because their coverage is so wide that they can cover, like in this last image, this scanner didn't have wide coverage, so you needed 4 different cardiac cycles to cover the heart. This scanner has such wide coverage, remember 16 centimeters, that in one heartbeat it could prospectively acquire all the information. So this was the big selling point with this scanner, that it can acquire all data in one heartbeat. And you can imagine how important this would be for atrial fibrillation cases. This would be maybe the most ideal scanner. You just find that, set it to an RR interval, which is long enough where you can acquire all the data in one single heartbeat. So this was, the big emphasis on this scanner. When we were choosing scanners, we elected, instead of wider coverage, to go for better temporal resolution. And this was the newest scanner on the market. This is what you are used to using, the Siemens Force, which is our dual source scanners. And this is a scanner which, as I had told you, has 2 X-ray sources and 2 detectors mounted at 90 degrees to each other. And the concept here, remember, is simply that now if I have to spin 180 degrees to get my information to create an image, I only have to spin 90 degrees, because the other 90 degrees is filled in by the other detector. So this scanner, just look at, compared to what you have seen, just look at, I've highlighted in red, its salient features. Number one, it has 2 heads, which is, its claim to fame. Temporal resolution using this technology with, a faster gantry speed, 2 heads, temporal resolution down to 66 milliseconds. So, very, very sufficient for functional imaging. Table speed. This can do 7 centimeters per second the table can move. I'll show you in the next image. So you can imagine how quickly you can acquire images. You can imagine in in trauma rooms where you need to get data quickly. In general radiology, this moves at 7.5 centimeters per second. So, and I'll show you an image of that. This table really moves, so you can acquire data very, very quickly. So we went with temporal resolution, and I will show you all the reasons why. So will it all translate to? If you have a better temporal resolution, it's going to be faster, more coverage, and it will translate to less radiation, less contrast, less time, less motion, and other problems. Now, with dual source, these are where some of the confusion starts, and the terminology changes a little bit, but the concepts are still very much the same. So we can still do retrospective helical scanning that y'all have seen. We can still do that. Not a problem. We often do it when it's where we need functional information. But we can also do another way. Now remember, if we want to limit radiation, prospective scanning is the way to go. So what this scanner can do is it can acquire prospectively in a step and shoot manner information to create an image over several heartbeats. And this is called what they call their adaptive sequence. So, or another word for it is prospective adaptive sequence. I'll show you images, it'll make more sense. And then finally, because the table is able to move so fast, we have a very high pitch. The table moves very, very fast. The scanner has a temporal resolution sufficient to also, in the ideal patient, be able to take a picture in one heartbeat. We call that our flash mode. And we'll talk about that. And that's actually helical acquisition. Okay, so let's talk about what normally, whenever you hear us saying, we want, over the T wave, we're talking about prospective EKG-gated helical imaging. And basically what you're doing is it's functioning as, it's prospective information. You are stitching, you're getting portions of the heart in different heartbeats, but you're able to do it in a short period of time because you've got two heads rotating. Whereas another mode, if you have a patient who has this nice slow enough heartbeat, you can acquire all the data in one heartbeat, and that's called, again, the flash mode. So this is, I know there's often confusion about these terms and terminologies, but because this scanner is so fast, it allows us to take the best aspects of the old scanner, which was temporal resolution, which was perspective scanning, right, to limit radiation, and we can do the same thing. We can do perspective scanning, but here we can do it over multiple heartbeats very, very fast. And okay, so I was going to show you what are the benefits of better temporal resolution. Well, it's been shown in phantoms, and we all have case examples of this, that, when there's motion just having better temporal resolution also improves the quality of the image. And this is just an example of a patient who had stents. You can now, because you take away the motion, you can peer inside the stent a little bit better compared to those old multi-detector CTs. Because we have now this ability to acquire data in one cardiac cycle in the right patient, the bottom slide shows you in the trauma case how fast that table moves. It literally does move that fast. Let's see it play again here, hopefully. But we can acquire an image in one heartbeat. So you can imagine how little time is needed for you to acquire an image. And what does that mean? You're delivering radiation over a much shorter period of time. So we can routinely getting studies less than 1 millisievert. An entire chest can be done with these scanners as fast as half a second. So we went with speed, and with speed came the ability to offer. Ability to offer much lower radiation doses. This is just a slide showing you that routinely you can do CTAs less than 0.5 millisieverts. And we're talking diagnostic scans. Even in the cath lab, you still need 2 to 3 millisieverts. So we're talking, if your average annual radiation dose is 3 millisieverts, 0.5 millisieverts, you have a whole anatomical assessment of your coronary tree. So, radiation dose has been, really markedly improved with these new scanners. If you're imaging less over a much shorter period of shorter period of time, you don't need that much contrast, right? Because you've taken your pictures and you're done with. There's no need for all this contrast going through the system. There's people who are publishing TAVR workups, 40 cc's of contrast. And that's a TAVR workup. You went all the way down to the femoral arteries. So imagine a coronary case, how little contrast they may need. And then of course the other, benefit of these, of having two detectors is you can send in different photon energies from one compared to the other. And what that can help you do is you can then get more into tissue characteristics, because different substances will behave differently based on how they attenuate, based on how they under two different energy photon conditions. So, and Dr. Chang is probably in his advanced topic will hint on this, but what it allows you to now do is to be able to look at different properties of the myocardium, be able to do perfusion imaging. So in one study, if you have this technique, you can get not only anatomy, but then you can also see perfusion. And with that, I don't have much experience, we're not doing it here, but these are the next steps that, we're trying to get ourselves involved with. And then this is just a quick slide reminding, and I kind of hit it on this about radiation doses. If you look at, I highlighted the dual flash CT. If we can do it in less than 1 millisieverts, you have, compared to other imaging techniques that we are using now, this is a remarkable difference compared to other techniques. So I hope you got a very good flavor of the basics of cardiac CT, hopefully understand it a little bit better, at least why we do what we do in the lab. And as the year goes on, we'll get more into some specifics.
So the contrast agents you guys use right now are all extracellular agents, right? So they extravasate.
They have the same kinetics as gadolinium.
Now, are there any eye-native contrast agents that are either tagged with albumin or something that become blood pool agents? So the question really is that most commercial contrast agents are extracellular agents, so they quickly wash out of the blood pool into the soft tissue. But are there any agents commercially available that somehow are tagged with something that they stay in the blood pool for a prolonged period of time?
That's a great question. I personally have not heard. Dr. Chang?
Not commercially available, but research definitely, yes.
Because, I mean, where it could be very useful is for venous imaging.
Venous imaging, yeah. Absolutely. Yes, sir, Dr. Q.
Great talk. Two questions. One is, so if you do a simple calcium score with the FACC scanner, then you may be going down to X-ray levels, to chest X-ray levels, right?
Yes.
Because all you're doing is a snapshot. You don't even need.
Yeah.
I mean, with one revolution, you're done.
Our DLPs are much lower than on the 64 slice. I'm not on the top of my head remembering the number, but it's now less than, it's 1 millisievert.
Are you
or
using
less.
flash when you do a calcium score also?
No, yeah, we use the same protocol that is recommended for calcium scoring.
So you're not gating for that?
We're gaining.
Oh, you're gating.
You're
Okay.
gaining, yeah.
Second question is, not uncommonly, we are in the echo lab and we hear Dr. Mamarian next to us, and he's unhappy. He's making statements, oh gosh, this image, we're going to have to bring the patient back,
That's not meant for this talk.
So,
Everything is perfect right now.
so my question is, when that happens, usually what are the most common sources of problems that make you be unhappy?
Yes. So Dr. Quinones, what he's hinting at is that, yes, CT is an unforgiving technique. I contrast this to MRI. If you, with MRI, you're standing there, you do the image. If it doesn't look like if there's motion or if there's an arrhythmia, you have a chance, because it's no radiation, you have a chance right then and there to correct your image or correct whatever was the abnormality was. With CT, once you've acquired that image, it's unforgiving. You've delivered iodine and you've delivered the radiation. So most of the trouble that we run into now is, yes, we have an exception. I hope you're not hearing as frequent as we used to back in the day of the 64 slice, because our temporal resolution is so fast now that if they have, as long as their heart rates, I mean, this scanner, they claim I've seen AFib studies, people going at 100 beats per minute, and the arteries are completely still. But motion is always an issue, especially if you didn't acquire all the phases. Just the phase that you acquired may have the motion, and that can make the image uninterpretable, and that's a tough situation. But motion is our problem, calcium is our problem, metal is our problem. Calcium metal can cause beam hardening artifacts. That's our trouble. Motion, either the patient's chest or arrhythmias, or calcium and metal.
So the patient moves with the test.
We're in trouble. We do a very deliberate, systematic, the technician goes in there, talks to them in great detail. Because what happens often is, they have whole instructions they have to follow. We practice with them beforehand as a way, a muscle memory when the actual scan happens. Because one of the biggest sources where we see a lot of problems happen is when they get that bolus of contrast. I don't know who all may have had a CT, but supposedly it feels very warm. And so patients may just then, gasp or take, just Valsalva a little bit. And that's a little bit, this scanner has taken its pictures by then, So, we're very systematic, we're very conscientious about really talking to them and emphasizing, stressing to them, please be motionless,
flash mode, we are not getting a X-ray like, dosage. And the main reason is our definition of calcium currently used is 130 Hounsfield unit or higher using 120 kV. As Faisal mentioned earlier, calcium react differently to different energy. So everything we use is based on 120 kV imaging. Exactly. So when you do a coronary CTA, we can go down to 70 kV, which 130 to 70 kV, basically you're giving 1/4 of radiation. So that's we were able to go down to less than 1 millisievert. The calcium score, as it's standardized right now, we have to do 120 kV. So even with the flash mode, we're still getting 1.5 to 2 millisievert of radiation, which, by the way, hasn't been that well standardized compared to regular protocol. We do that here. We do it with flash mode here with a Siemens scanner, but I really would like to do a study, same patient, scanning with flash mode and prospective mode. So bottom line is, there's possibility of doing a CAT scan of the heart with the radiation dose of the chest X-ray, but we have to use very low kV imaging. So I don't know if that makes sense.
And that would set up a whole new set of standards to define the calcium?
Correct. So the calcium score that we clinically use is based on 120
Right,
kV
when I
imaging.
said,
Okay.